Okay, so welcome to this Q&A on first day before the exam. This is a casual session, so feel free to ask questions. You don't have to stay the entire time. It's just a way for me to just answer whatever last minute questions you have before the exam and get you 100% ready. So you might not be able to see this on your screen, but I have to admit people in and just monitor the chat. So I'm doing multiple things. There are a couple of housekeeping items that I want to discuss. This meeting is being recorded and will be uploaded onto YouTube. So if you miss something, you can go to YouTube and rewatch it. I do have three tips that I always give at these Q&A sessions. One is that it's really important just to keep calm on the exam. If you find yourself getting flustered or anxious, take 7 deep breaths and continue. Typically, you do have enough time to complete the exam, but it's really important that you read the questions slowly and don't rush through things. Remember, as I mentioned, there are 25 pilot questions on the exam. So even if you spend a lot of time on them, even if you get flustered by them and get it right, you still get exactly 0 marks for it. So 25 questions in 165 is about 1 in 8 roughly. So it is important that if you get flustered by a question, don't worry too much about it. Just mark it as undone and go to the next question. And the last tip I have is that it's important to not change your answer. Typically, your first answer is actually correct. So for people who unfortunately did not pass the exam, I talked to them, I looked through their kind of how they did on exam. And a lot of times they change their answers a whole bunch of times. So I would really suggest against doing that. Typically, your first answer is typically the correct answer. Yeah. So with that, yeah, this is a very casual session. Whoever has questions first, please feel free to ask them. I hope somebody has some questions.
Hello.
Hello, who's this?
Uh,
Kajal?
yes. How are you doing?
Good. How are you doing, Kajal?
I'm good. I just wanted to clarify something about the blood sugar monitoring with the 2021 update.
Sure.
So somebody who's at like target with their sugars and on insulin more than once a day,
Hmm.
it says that they recommend testing sugars 3 times a day. I
Hmm.
just want to confirm though that this like doesn't necessarily apply to like certain populations. Like for example, let's say you have somebody who drives for a living and their A1C is on target, but they have insulin twice a day. Like
Hmm.
they still need to test more than 3 times a day, right? Or is that like that's what I'm kind of confused.
Yeah, that's kind of like a gray in between area. So you're kind of referring to the driving guidelines as well, which apply to
Yes.
commercial drivers and stuff like that.
Yeah.
Sorry, I just have some people who are trying to get into this Q&A. Just give me 1 second to admit them. So in that case, I think if they're a commercial driver or something like that, you go with the commercial driving guidelines because that's more specific.
Hmm.
The new guidelines, the 2021 doesn't actually cover, whoopsies, doesn't actually cover commercial drivers or things like that.
Hmm.
So in that case, if they're a commercial driver, I'd go with the commercial guidelines.
Oh, okay. And is there any other like population that you can think of that would deviate from the 2021 recommendations? Or is it just commercial drivers that's all I could think of.
That's all I can think of. Like commercial
Mhm.
drivers, airplane pilots. You wouldn't want an airplane pilot going low in the middle of their flight.
Mm. Yeah.
Those kind of commercial driving people, professional drivers, let's say.
Okay. Sounds good. Thank you so much.
No problem. Okay, just admitting some other people into the room. Anyone else?
Esmond, I had a question that was on, this is Annika.
Hi,
I had a
Annika.
question that, hi, I had a question that was on one of the practice exams. I was going to type it out, but it's way too long, so I'll
Okay.
just read it.
Oh,
Um,
actually, for
so,
my practice exams, if you could just email me, that'd be great.
oh, okay, it
Yeah.
was it was more or less like just I didn't really love the answer. I guess it
Okay.
was just because it kind of was assuming that the patient was not compliant, even though straight up in the question it says that she is compliant with her insulin. And then she's losing weight and she's super excited, but her A1C hasn't changed. And the answer is suspect that she's omitting insulin to lose weight. Um, Even though in the question it straight up says that she's compliant with her insulin.
I think I know which question you're talking about. You can email me further about that. But I
Okay.
believe it says she claims she's compliant.
No, it says she reports that in all of her home readings are on target and she is compliant with her insulin.
Yeah, she reports that she is compliant and all of her home readings are within range. Like it's
Yeah.
coming from her.
So do we have to assume that she's lying?
That in that particular question, I worded it to make it kind of clear that she is lying, but we can take that offline and you can email me about that question.
Okay, yeah, I just didn't know because to me I'm like I would try to believe the patient
Hmm.
before and like dig deeper. Like what
Hmm.
if she's working out a lot? What if she's like eating different foods and like,
True.
you know,
And in the exam, one of the reasons why I put that question in there is in the exam, there will be lots of questions like that where you don't like the answer, but you have to choose one of them. And so you you can argue with the exam people later, but you still need to find out you need to find out the right answer to pass.
okay. Yeah, I just wasn't really sure because it just to me it sounded like we had to assume that she was lying. I didn't really love that. But
There's going to be a lot
anyways,
of question answers on the exam that you're not going to love.
yeah,
Trust me on that one.
okay, for sure. Thank you.
No problem. Okay. So Jabber asks, how often should screening be done for type 1 diabetes? The recommendations for type 2 are clear, but I find the guidance for type 1 diabetes screening a bit confusing. Are there any specific recommendations? So the answer to that would be there are no screening recommendations for type 1. We don't understand exactly what causes. We have a better idea now, but we don't have a clear understanding of what causes it. We don't have any screening processes that uh, have shown to have shown to be powerful enough and clinically relevant enough to test all the time. So the answer to that is that there are no specific recommendations and typically you don't screen for type 1 diabetes. No problem. Jabber? Okay. So Queenie asks, as per the type 1 for children and adolescents, level 3, how much glucagon? Yeah. So I'm not sure about this either. I had some people try to ask other pediatric people, like on the exam form, I believe Serene tried to ask people. I don't work in pediatrics, so I don't really have a good answer for that. It's not mentioned, so I'm not sure for that one. I suppose like it's one of those corner cases where if the new guidelines don't cover it, you could default back to the old guidelines. But yeah, I'm not sure for that one. And then for Queenie, you're asking, as per type 2, page S251, screening should be done 2 years if there are three factors, non-pubertal two factors in pubertal. However, it is not on your cheat sheet. Is there a newer update on that? No, I don't believe there is. Hasn't been a chapter to the type 2 children guidelines. So yeah, and I don't know how to memorize that for the exam. Like it's that risk, those list of risk factors is very similar to the adult one. And so I don't know if it's worth memorizing two lists separately for something that might not show up on the exam. But yeah, but there's no newer update than the type 2 one. Okay. Okay, anyone else have any questions? Hi, can someone who is on SGLT2 for CV protection qualify for remission? Can you talk about a bit remission on screening A1C? Okay, sure. So I believe in the guidelines, it says if they're on medications, then they're technically not at remission. But let me double check here. Because I believe in the actual definition itself, they say, am I in the right chapter? Yeah, okay. Bum, 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 bum. Okay. So in terms of screening for A1C, minimum of 3 to 6 months, right here. But I believe the definition says no medications at all somewhere. Not be taking any hyperglycemic medications for 3 months. So yeah, that's kind of a gray area. But for the exam purposes of the exam, I would go with they have to be on no medications whatsoever. Hope that answers your question, Rishma.
Yes, yeah, thanks. And also maybe another gray area which I thought in the same chapter was about the 3 months. In one recommendation it said 3 months, and the other one said minimum 6 months. So I wasn't really sure in terms of, I guess, depending on how the question will be phrased, but anywhere between 3 and 6 should be an okay answer, I believe.
I think so. Like
Okay.
in terms of like the screening.
Yes, yeah, the screening to make sure they are in remission.
Um, double check
Mm.
that.
Yeah.
Because technically, like in real life, if I have a patient whose A1C is like 5.9, I'm telling them to see me in 6 months. I've got too many patients to take care of. So
Okay. Okay.
so yeah, it says 3 or 6 months here, but in real life I would go 6 months.
Sure. Okay. Okay. Thanks.
Okay. Okay, so I'm on to IG now. Thank you, Esmond, for going over the topic for the exam. I have a question regarding continuous subcutaneous insulin infusion. Is using a health pump with mealtime flexibility and A1C decrease? I would assume so. Definitely it helps with mealtime flexibility. Like you can eat whenever and just you have your pump with you always, you just inject it. If you have a small meal, you can just give yourself a small one. Also, a lot of pumps have this they call it dual wave boluses, where let's say you're eating something really fatty, like pizza or something like that. What you can do with the dual wave is actually give yourself a small bit of insulin now, and then over time give yourself a longer bolus of insulin. Because in real life, that's what assuming you don't have diabetes, that's what your body would do. Um, it's not like in with insulin pens, you estimate your food, you give yourself a big injection of it, and then it's like, oh, I actually don't feel like eating that much, and then they go low. So yes, it definitely helps with mealtime flexibility, and I believe in the new guidelines, it did say that it helped with an A1C decrease as well. In Dr. Sue Peterson's talk, they talked about how all the previous restrictions have been removed for qualifying for an insulin pump. Like in Alberta, you used to have an A1C of 9, below 9 twice to qualify for a pump, and the insulin pump program and seeing an endocrinologist and all that. All of that has been removed. So the new recommendations of offering aid to everybody at like automated instant delivery and CSSI to everybody, yeah, is active. Hope that answers your question, IG. For GDM screening, there's a preferred and alternated approach. Do we need to memorize both? Probably like the problem, like the one of the reasons why the pregnancy guidelines is so long is because it's hard to do research on pregnant women. That's why it's like there's all these alternate methods and preferred methods because they don't really know which one is the best. I did hear that the pregnancy chapter is getting a big update soon though, so hopefully there'll be less to memorize after that. Um, you know, if you're kind of maxed out on info and you can't memorize much more, maybe just memorize the preferred and hope that alternate doesn't show up on the exam. But I don't know what will show up on the exam myself. Hope that answers your question, Queenie. Okay. Anna, should patients that have an A1C of 1.5 above target be start with just lifestyle? So if they're above 1.5, I have to admit some people. Above 1.5, I believe the guidelines say to start them on 2 medications. So let's just take a look at that. So like definitely not. You would not have lifestyle for people over 1.5. Though like so for that's for the exam though, but in real life, I have had patients who are like, okay, I'm really willing to work with you, Yasmin. I'm really willing to turn everything around, you can put a sensor on me to double check. I promise I'm gonna make changes, and some of them do. So what is that? Maybe it was in the old guidelines. Regardless, for if they're above 1.5% of their target, I wouldn't just start with lifestyle changes. It'd be lifestyle changes and metformin at the very least, probably another medication. Yeah, the old guidelines had this thing, had another separate where it's like above 1.5, you do this and stuff like that. I assume that still applies. I'm actually surprised they didn't put it in this one, actually. Let me check the 2021. That's not it. Yeah. So if above, start metformin plus a second agent. And so I would still say that applies. Oops, where am I in the questions now? Um, okay, I'm at Anna at 513, so I hope that answers your question. Thank you. I know if they mentioned yes, so if they have like CKD, then SGLT2 would be preferred. For heart failure, it's actually just for Ziga and Jardiance now. Invokana doesn't have a specific study with heart failure, so it was removed from the 2024 guidelines. It's in the 2020 guidelines, but in the 2024 guidelines, it was removed. So I just learned that from Dr. Sue Peterson on Tuesday. So for heart failure, it's just Jardiance and for Ziga, not Invokana. Okay. Rishma, any suggestions on what to focus on in terms of DK and HHS? Yes. So I don't think you need to really know, you don't need to memorize like a treatment. Like I've never had a test question where it's like how much how much potassium do you give a person or something like that. What I would suggest is you know the signs and symptoms of DKA and HSS, know like that SADMANS and stuff like that is interrelated with it. Um, know know the differences between DKA and HSS, know what can cause it, and yeah, that's what I would know for the exam. But you don't need to know treatment, or like at least I've never been asked for treatment. And important note on children. For children, you always give fluids first before insulin, because for children, if you give insulin, sometimes their brain can if you give insulin first in DKA, the brain can swell, causing cerebral edema. In children, their skull isn't big enough. So if the brain expands too much, then that actually that's incompatible with life, and so for children, you give fluids first before insulin. For adults, we apparently have more space in between our brains and our skulls, so you can give it insulin first. But that's something to remember for children that sometimes shows up on exam. Okay. Oh gosh, don't say that, Carol. No, Dr. Sue Peterson has requested that we not record her sessions. So that's why it was not recorded. For me, it's just me, so I'm happy to record them. When the client will be screened by alternative approach, is this for, I'm assuming you're talking about the pregnant people, or this is in pregnancy, Queenie? Yes, okay. I actually don't know. For pregnancy, I don't have any experience in diabetes in pregnancy, so yeah, that would be, yeah. I don't know when they would use the alternative approach and preferred approach. So yeah, if you're looking to save time, just memorize the preferred approach. Okay. Chapter 9 update says ISCGM has been studied for accuracy and safety, and it's in good agreement with CBG. Then 2 paragraphs down, it says there's been no randomized control trials using ICE. Do you know what page number that is, Kajal? In the chapter 9 update pregnancy section.
I'm just on, the subheading is called glucose monitoring in, oh, sorry. I mean, it's called accuracy of RT-CGM and ISCGM. Let me see if I can find the page. Oh, I guess 582, page 582.
Okay, here. Okay, the effectiveness for glycemic or fetal outcomes has not been studied in pregnant women. Okay, let me just see here.
So on the left side, so glucose monitoring in women with diabetes during pregnancy. So under accuracy of real time and intermittently scanned, basically that last sentence in the paragraph says the use of ISCGM in pregnant women has been studied for accuracy and safety.
Mhm.
And then 2 paragraphs down, it says there's been no randomized. It's like at the very bottom of page 582. On the left.
Like you're talking about just this one right here, right?
No, on the left side.
On the left side, I'm sorry.
And it's like the very bottom. To date, there have been no randomized trials using
Okay.
ISCGM.
Yeah, that's so this is no randomized trial, and this is effectiveness on glycemic or fetal outcomes, so that's affecting the baby. This is type 1 and randomized 325 women with type 1 diabetes. Yeah, that's a confusing statement. Someone else did mention it somewhere. I can't remember my answer to it. So this was done on type 1 women. So it seems like in type 1 women there's some evidence. Actually, no, I believe I believe the Dexcom is approved for pregnant women, but it's not for type 2. Can you put this in the exam form and I can try to research it more later? I believe the answer, I think I answered this question before. I believe the answer is that Dexcom is actually approved for pregnant women, but the Libre is not, and no sensor is approved for type 2 pregnant women. I believe something like that is the answer. So could you put this in the exam form and I'll look up to answer later. Kajal, I just can't remember it off the top of my head right now.
Sure, sounds good. Thank you.
Thank you. Okay, so let's move on. Oh, when was this? It just came out a couple days ago, I believe. So, I don't think yeah, that's not an exam. I think it only came a couple days, a couple weeks ago. So it's definitely not on an exam. Okay. Yeah, I think it just came out in March, so it is not on exam. It hasn't even come in I get the journals. It hasn't come in the journal yet, so I don't think it's on exam. Oopsies, what's this? What's this image thing? Sorry, I can't download it. Okay. Queenie, also my colleague took the exam today. She mentioned the multiple questions are not straightforward. Looks like all the answers are incorrect. Oh, I thought they got rid of those questions. Like, from what I've heard was that they got rid of all those not questions and stuff like that. I kept it on my exams just to force people to read the question carefully, but I guess it's a good thing I kept them on then. So it's important to read the question carefully, again, staying calm and reading the question slowly. My other colleagues and myself recommended, oh, okay, multiple choice, yes. Oh, okay. In the healthcare setting. Okay, I'll have to take a look at that, Carol. Thanks for giving me some insight in that. Again, I don't have any experience in pregnancy, so yeah. Does the use of CGM decrease A1C? Yes, indirectly, in that people notice that, oh, when I have ice cream, it does really go up, and I should probably stop doing that. So you could say, yes, indirectly, CGM decreases A1C. But it's not like the device itself is decreasing the A1C. It's that they realize, oh, whenever I have birthday cupcakes, it goes up, so I should have less. Could you highlight what is the main update on the chapter for self-monitoring of glucose? Okay, Josie. There was a couple of big updates. Like in the old guidelines, they didn't have all this stuff like flash and glucose monitoring and when the first guideline in 2018 when the guidelines came out, it was all capillary blood glucose. It's just nowadays we have all these Libras and Dexcoms and stuff like that. So I would say that was the biggest update. They added all this new terminology, all this new studies on ISGM. They also changed around they gave these values for time and range and stuff like that. They also changed around the recommendations, but I felt that these recommendations were less clear than the 2018 ones. I felt that the 2018 ones fit into boxes very neatly, whereas these ones don't really. And yeah, but the main update was on like sensors and stuff like that, because in 2018 there weren't any. Queenie Lau, is the Dexcom G7 more accurate than the Leap 2? I believe it is, but I would have to double check. And then, yes, the Libra 3 is supposedly coming out sometime in the summer or the fall. So that one is more comparable to the G7. But yeah, when the Libra comes out, it's kind of up in the air. They told me it was last year, then they had to cancel this thing, but apparently it's coming out this year. Yeah, no one knows. Yeah, so like I had a conference thing that I was preparing. They had booked a slot, the Libra people. And then when Libra 3 didn't come out, they had to like scramble to find another speaker to just fill the spot. So yeah, it seems they don't know when it comes out yet either. Okay, any other questions, concerns? What are the major changes? So IG asks, what are the major changes per chapter 12? Yeah, chapter 1241. I would say that's, yeah. The biggest changes would be you used adults A1C for everything now. It used to be like in the 2008 one, it used to be 8, then in the 2018 one, it was 7.5, and now it's just 7 for the A1C target. And you use the same A1C targets as the adults, 4 to 7 and 5 to 10. They also talked about a lot more encouraging people to use pumps and stuff like that. Um, so yeah, and that term all patients, yes, it's all patients who are willing to use and wear the pump. You can recommend it to them. Another big thing they did, and I feel this is very controversial, this is adjunctive therapy thing. So they talked about this adjunctive therapy, metformin, GLPs, SGLT2s, and they made it sound like it's okay to prescribe it. But the answer is actually no. It is therefore not possible to make a strong treatment recommendation. And if you look at all the product monographs, let me show you, let me just look up let me just look up Jardiance, for example. You can see that here's the contraindication black box. Jardiance is not indicated and should not be used in patients with type 1 diabetes. So I feel this puts us in a real difficult position because let's say, where am I? Sorry. Okay, let's say so basically we're supposed to talk about these medications now to people with type 1. And I think there's a good chance that they might say, hey, I want to be on Ozempic, or hey, I want to be on Jardiance. But then, like, in terms of prescribing, like, I'm not willing to prescribe that. It says, like, if anything happened to the patient, I can't blame, the lawyers wouldn't attack the drug company. The drug company can say, hey, right here, we said should not be used for type 1 diabetes. And if they say, oh, well, I was recommended by the guidelines, they can say, oh, right here, we do not strongly recommend that. So the lawyers would go after me. And so I'm supposed to talk about these things, but if they actually wanted to start these things, I'd have to refer them to an endocrinologist. And talking to Dr. Peterson and Anita says she's worked with a lot of endocrinologists who would never touch type 1 and SGLT2. So I think this puts us in a really tricky position where we're supposed to talk about these benefits, but we really can't prescribe it, and we might not be able to find a prescriber, and I would have to like consult a lawyer or something like that before I recommend it. So those are my thoughts on that. So sorry to get off track, but IG, to answer your question, yeah, the major things are the target changes, the changes to insulin pumps, and this adjunctive therapy. I hope that answers your question. Yes, I do. Everything should be using the pump. Oh yes, and that greater than equal, it is great. It's 7 or below. That is a typo. Queenie, for Libra 2, does it count as real time or ISCDM? So I believe another student asked that. I believe if you're using the phone, then it's considered real time because it's constantly pushing it. The sensor is constantly pushing the data to the phone. If you're using a meter where it doesn't communicate, then it apparently still counts as ISCGM. So I guess it depends on which device they're using is the key to answering that question. Though I hope the exam doesn't get into that much detail. Okay, perfect. Someone answered it. Okay. Any other questions? Um, am I correct Anna asks, am I correct to say not to prescribe SGLT2s, metformins, and sulfonylureas and alpha glucose inhibitors if my eGFR is less than 30? Okay, so there's a chart for that. Let's see. This is 2024? No. And they're always updating this chart, which is kind of frustrating. My website is like really slow right now. Let's try that again. There we go. Okay. It is right here. So let's take a look at that. So for SGLT2s, no, some of them you can use below 30. Like you can use DAPA below 30, even at its regular dose. Metformin, you'd use a reduced dose. Alpha glucosidase inhibitors, nope, you can still use it at 30. Yeah, a lot of the cutoffs are, yeah, some of the cutoffs are 15, but you would have to look at this chart. So, yeah, Anna. Yes, this chart is constantly being updated. So you have to like, every time they come up with something, this chart gets updated. So you have to use the most current one. Okay. Any other questions?
Could you just, I think people answered in the chat, but could you just confirm the new CKD chapter is not, that's
No, it's not
too
on.
new. Okay.
Yeah.
Okay, thank you.
IJ asked, would you remind us again of to prevent MACE? Sure. Okay, which and Rishma has the same question. So primary prevention here. Let me go look at it. Look at those things. Primary prevention is preventing a heart attack from happening in the first place. Then secondary prevention is preventing a heart attack from happening again to someone who has had it. The medications are actually the same for both. So if you look right here, so if they have. So if a person has high CV risk, then an SGLT2 or the GLP-1 or SGLT2 should be given. So again, it's dulaglutide Trulicity, liraglutide Victoza, or subcutaneous semaglutide, which is Ozempic. Now there was a study that came out in March or April that showed uh, oral semaglutide, right? Ribellicis also has some CV benefits, but I think that's too new for the exam. I'll just go for the guidelines. And yeah, and then for the SGLT2s that you use for both primary and secondary, it'd be empagliflozin and canagliflozin. For Ziga, did their study, and unfortunately, they didn't show much in terms of cardiovascular benefit, so that's why they're not on this chart. So the medications for both of these, IG and Rishma, are the same. It'd be these three for GLP-1s and these two for SGLT2s. Hope that answers your question, IG and Rishma. Sarah asks, can you confirm that linagliptin is, no, I'm pretty sure that's not the case. You would have to adjust their dose for sure, especially for SIDA. So for SIDA, like you would avoid a dialysis. Linagliptin is this one. Okay, so for the exam, I guess you could use it no matter which one. Tradjenta, yeah. In real life, I don't know if you really use Tradjenta in dialysis. Yes, I've heard some endos say no, and some endos say yes to that, but that's kind of a corner case. Typically, if their kidney function is that bad, typically they'll be on insulin already. No problem. Okay. I'll just wait a minute or so, see if there's any other questions. What about for heart failure with ejection fraction? So, for preserved or reduced ejection fraction, for the exam, you would go with Jardiance or Forxiga because they've had, like if you look down here, they've had specific heart failure studies done with it. So let me see here. Yeah, reduced or preserved, you go with DAPA, which is Forxiga, or EMPA, which is Jardiance. Because they have done specific studies with heart failure. For in real life, though, most people think that this is a class effect, and you could probably use Invokana as well. But for the exam, go with DAPA and EMPA. I hope that answers your question, Rishma. Anika, can you review the initiation statin because you need to go? No, okay. So for that, that's a really good question. Anika, for that one, what's really important to remember is that you go from top to bottom. You don't go bottom up. Here, let me show you why it's confusing if you go bottom up. Give me one sec. So the best one for that, actually, Diabetes Canada already has a provider tool for that one. Okay, let me see here. Oopsies. Oh, did it change this recently? No, here. Okay. So you go you go from the top because if they have previous cardiovascular disease, it overrides everything else. So you don't need to worry if they're under 40 or had 15 years or have microvascular disease. If they've had previous macular vascular disease, they qualify for all the medications. So if you press yes here, and that's when they have diabetes, you can see it's all yes. Because if you go from the bottom, then it's like, okay, they only get statin, but it's overridden if they have this. Or if they have microvascular disease, then okay, they qualify for statin, but it's overridden if they have that. So it's you always go from the top. It's just so much easier that way.
I think I'm just thinking of the other, there's like that one, this one, where it like goes from the bottom. Maybe
Uh,
I'm just getting it mixed up.
uh, mm, yeah, for this one, it's way easier if you go from the top because then you can say no, and then it's like, okay, they don't need ASA, then no, then they don't need ACE. But if you go up, like let's say if they're under 40, let's say they're 30, I don't know, let's say they're 20 years old and have diabetes for less than 5 years, then you'd say, oh, they need a statin. But if they've had a heart attack, then they automatically qualify for all of it. So instead of memorizing, okay, age 40 and age this, it's like, oh, but if they have a CV event, then it's also all this. You might as well just go from the top and then eliminate it as you go down.
Okay.
Yeah,
Yeah.
does that
I
make
think I was
sense?
just I think I was overthinking it.
Okay, like a lot of people get confused by this chart, so you're definitely not the first, and you won't be the last. Um,
Yeah.
but always go from
Okay.
the top for this. It makes way more sense if you go from the top.
Yeah, I guess like just because I've never like had to prescribe or even adjust, like I don't have any medical directives to adjust heart medication. So
Hmm.
I think that's why it's like I don't like I'm not super familiar with them. So this chart just is very daunting.
Hmm. You can practice using this, like you can switch it around and try to guess before you make the recommendation. Before you yeah, you guess your answer. But for this one, it is actually easiest to pretend to you are the prescriber and going from down to up and then figuring out the answers. Hmm.
Sorry, down to up. You mean
Oh, sorry, I'm getting
up?
confused now. Up from the
I
top
was
to the
like,
bottom, to the
no.
top to the bottom.
Okay.
Answered like, I don't know, like 40, 50 other questions today. So
Yeah, it's all good.
so from the top to the bottom, yes. Okay. I hope that answers your question, Annika. Okay, where am I? Okay, I'm looking at the chat and statin. Okay, Queenie asks how much detail should we remember the carb counting, food, and also the glycemic index. Um, not a ton, I would say. Like it's kind of useful in real life because people ask, oh, wait, can I eat this or that? But there's already like a ton of numbers you have to memorize for the exam. And I like to like it may show up on exam, it may not. I think screening for sure will show up, targets will for sure show up. Um, you know, those kind of things will for sure show up. But whether like pumpernickel has less glycemic than rye bread, that might not show up, and then you memorize that for nothing. So I think you should know, try to be familiar with it, but I wouldn't memorize it. I think there's more important numbers to memorize, Queenie. Oh, you have more here. Should remember most of the foods on the Beyond Basic. I just memorized a couple of them because there's more important numbers to remember. Okay, so and yeah, and as Annika, I'm just skipping ahead. As Annika mentioned, more fiber equals low GI. So that's a easy way to kind of guess if needed. Okay, so Queenie, for CV protection statin and ECG statin, sorry, what? Stat protection? CV protection statin ECG screening for statin 40 years and statin oh, ECG. Okay, I'd have to look that up. I know what chapter you're talking about. Yeah, let me take a look at that. I believe I had a question on the ECG screening that was it was a little tricky because I said like he had poor foot care, but his poor foot care means he doesn't wash his feet. It doesn't automatically mean neuropathy. Oh, thank you for that. Yes. Okay. Sorry, I don't have my full thing with me. So 166 says okay, yeah, right here. Yes, so in 176, so that's the next chapter. - 174. Yeah. So even if they don't have any risk factors, if they're above 40, then you would perform an ECG from how I interpret it right here. Yes, without any risk factors, without any, yeah, that's correct, Winnie. Okay, so Annika says, yes, more fiber equals lower GI. For Indigenous folks, screening should start now to 6 to 12 months. Is there a particular age in which we start in this population, e.g. kids versus teens versus adults? Okay, Annika already answered it, 18 plus. Oh, and I apparently saw my cheat sheet as well. Okay, good. That's wonderful. So there's this thing also called overstudying. Like, I don't think you should study like to the very last minute. I think you should, relax, at least try to have a couple hours relaxing before you write the exam. The night before, don't study right until you sleep and everything. Like I want you to kind of try to relax before you go to sleep. It's more important to keep calm. Like, yes, you have to study, obviously, but it's more important to keep calm and to read the question carefully to catch those not questions, to catch those all the true except questions. So yeah. Okay. Oh wow, it's 5:50 already. Oh my gosh. I can't wait for Sunday as well, trust me. Uh, okay. I'll just wait a minute and yeah, I can't wait either. No problem. I hope you found everything useful. Like, yes, 7 briefs, 7 breaths for A1C, just to relax. Yeah. Okay, yeah, no problem. I hope you found my course useful. I wish you all the best of luck on the exam, and remember, just try to keep calm. Also, I really do want you to use your CDE after you pass this exam. You know, some people like get their CDE and don't really use it. So, if you have a complicated case, I'll tell you a funny story. I'll tell you a funny story and then I'll end off on that. Like I remember the first time where I prescribed insulin to somebody. It was just to this sweet little old lady that I had known for like probably had been going to that pharmacy for like over a decade. And so her A1C was way out of control, like 13 or something like that. So I had to give her insulin. And I remember prescribing her insulin. And then that was my first time doing it. I triple checked the calculation. And then I went home. And then I had this dream where it was like she tried insulin, she had a low, she fell down the stairs. Somehow the cops came in, figured out I was the prescriber. And then when I would wake up and go to the pharmacy the next day, there were cops there to put me in handcuffs because I caused this low. So it's perfectly normal to get nervous, to get nervous, and especially when prescribing or taking care of people with your first patient with diabetes. But if you do have like a complicated case or a case you want to run by me, even after the exam, feel free to email me. Now in the summer, I don't check my email often, so don't email me some sort of emergency case. But if there is some case you want to run by me, feel free to do so. Okay, thank you. Okay, so I'll try to get this uploaded onto YouTube as soon as possible. And again, I wish you the best of luck in the exam, everyone. Have a good night. Okay. Stop sharing. Why am I stopping? There, stop. There. And then end.